Hello and welcome to today's webinar entitled San Diego Hepatitis A Outbreak and HCH Health Centers Involvement in Disaster Response. I'm Michael Durham and I'm the moderator for this webinar, which is presented by the National Healthcare for the Homeless Council as part of our spring virtual training with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This is a 60-minute presentation with the final portion reserved for Q&A. If you have questions for the presenter or you are experiencing technical issues, please use the chat box below the presentation slides. You may also call the Council's office at 615-226-2292 and ask for Julia. The session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. If you plan on claiming credit, a window will appear about 40 minutes into the presentation with instructions for you to follow. Please note that the text-in code will only be available during this session. So our presenter today is Dr. Jeffrey Norris. Originally from Salt Lake City, Dr. Norris attended medical school at the University of Utah, followed by a residency in family and community medicine at the University of New Mexico. He is now medical director of Father Joe's Villages, a large homeless services organization in downtown San Diego. So with that, Dr. Norris, you can take it away.
Thanks so much, Michael. I appreciate it. A quick disclaimer that this activity is made available through HRSA, through the Bureau of Primary Care, and its contents are solely the responsibility of the presenters and do not represent the official views of HRSA. Secondly, I have no relevant financial disclosures of conflicts of interest to report relevant to this presentation. First, before I really get into the meat of this presentation, I want to get a sense of who is on the webinar today. I know most of the folks are likely from Healthcare for the Homeless Health Centers, but I know there's some folks who are not part of health centers, and even those who are part of health centers, I want to get a sense of who you are and what your respective roles are. So I'll give folks about 10 more seconds to fill out the poll that just popped up on the screen. Just click who you are to give me a sense of where you come from. All right, great. It looks like we've got a little more than a third of folks not part of a health center. About a third of folks are administrative folks at health centers, and then a mix of other folks, consumers, clinicians, and folks in other roles at health centers. All right, moving on. The learning objectives for today are to understand the nature of the hepatitis A virus, to describe the epidemiology of the hepatitis A outbreak that started in late 2016 and had the majority of the cases in 2017, to analyze the community public health and health center response to the hepatitis A outbreak, and to talk about and list the actual causes, the root causes of the hepatitis A outbreak. First, I want to give you all a little bit of background on what hepatitis A is. Even those clinicians, nurses, etc., who are on the call today probably haven't seen much in the way of hepatitis A in the last couple of decades because it simply isn't that common these days. So even for you folks, it's probably good to give a little bit of background on hepatitis A. And of course, there's folks on the call who are not clinical folks, and so this background will be especially important for you all as well. So hepatitis A is a viral illness. Its symptoms are varied, but typically include some mix of the following: nausea, vomiting, abdominal pain, fever, decreased appetite, and or yellow skin and eyes, which are known as jaundice and scleral icterus. Hepatitis A can cause very serious liver damage, liver failure, and or death. It's a pretty serious illness when it occurs in adults. Children, it's typically not as serious, but in those susceptible, it can be very, very dangerous to your health. It's transmitted by the fecal-oral route. What that means is that if people come into contact with small amounts of fecal material, and that then is introduced into their oral cavity, into their mouth, and ingested into the GI tract, they can become infected with hepatitis A. The way this typically gets transmitted is through some contaminated food or water source. So that means there's a small amount of fecal material that gets into a food product or a water source, and then people then consume that food or water and become infected. That's the most common way that hepatitis A is transmitted around the world. However, it can also be transmitted directly person to person, from an infected person to a non-infected person. Or if somebody comes into contact with small amounts of fecal matter in the physical environment and they then ingest that material. That could be a doorknob, that could be a crosswalk button, that could be a sidewalk or a handrail or what have you, some small amount of fecal material in the environment. Hepatitis A has a fairly long incubation period compared to a lot of other infectious diseases. The incubation period is estimated to be somewhere between 15 and 50 days. What that means is from the time that the hepatitis A virus enters your body until the time that you start having symptoms is 15 to 50 days. And that's quite a long period, especially when you get on the 50-day end of things. That's quite a long period of time. Going along with that, people typically don't start to show, people are typically infectious 2 weeks before they start to have symptoms. So you could be walking around, feel completely fine, yet still be spreading hepatitis A if you're infected. Also, you can continue to spread hepatitis A 1 week after symptoms stop. Hepatitis A is pretty common in the developing world, and the reason is that it's typically in water supplies or in tainted food supplies, and a lot of children become infected at a young age and thus become immune to the virus at that young age. Most of those children are not that severely affected by the infection. Some of them have no symptoms at all, and most have very mild illness. In the United States, however, hepatitis A has become very uncommon over the last couple of decades after the introduction of a vaccine. This next slide really demonstrates that drop-off in the incidence of hepatitis A over the last couple of decades. So this figure shows hepatitis A cases by year, the incidence by year in San Diego County from 1994 to 2018. Back in the mid-90s, you can see there are around 500 to 600 cases or so per year of hepatitis A, and the vaccine was introduced in 1995. And after the vaccine was introduced, things started to drop off ever so slowly, and then in 1999, California, as a high-incidence state, introduced the vaccine as part of the routine schedule for children, and the rate continued to drop off. Then we get to 2006, and the hepatitis A vaccine became a routine vaccination for all U.S. children, regardless of whether they were in a high-incidence state or not. And in San Diego, after that, we continue to see a drop-off until the incidence per year was less than 50 for the most part. And of course, then we get to 2017, circled with the red circle, and we had our outbreak. We can see a giant spike that really brought us back up to an incidence that was close to what it was back in the mid-90s. I will say, of course, that 2018, we're only a couple of months in, and technically the outbreak is not yet over, and so that number might rise, but we surely hope it gets nowhere near what it was in 2017, and we don't expect it to. I want to give you a little bit of background on homelessness in San Diego, Father Joe's Villages as an agency, what we do, and how those two things relate. So you have a backdrop for our response as a organization and also the county's response here in San Diego. Homelessness in San Diego is quite a major issue. We have the fourth largest population in the country based on the 2016 point-in-time count, which showed that 9,116 individuals were on the street. Of course, that's not the total number of folks who are affected by homelessness in the course of a year, but rather a cross-sectional survey that was done early in the year in 2016. We don't yet have final numbers for 2017, but nonetheless, these numbers are quite high compared to most other cities throughout the country. And unfortunately, homelessness has been increasing and worsening year by year here in San Diego, except in one group, and that's veterans, with the VA's major push to decrease homelessness among veterans. And my organization, Father Joe's Villages, has been a part of addressing that, and we partner directly with the VA here in San Diego. Homelessness in San Diego is worsening because of a number of factors that are common culprits in other cities where homelessness is worsening. Number one is the increased cost of living year after year. San Diego has become a relatively popular place or sought-after place to move to, and that has resulted in the cost of living going up with time, especially the cost of renting a place or owning a place. And going along with that, there's been a very drastic reduction in the amount of affordable housing over the last couple of decades. We have lost tens of thousands of units of affordable housing, and there's been a drastic rise in the amount of higher-end housing, more luxury apartments and condos, that has counterbalanced that. Because of all this, we have a very low housing vacancy rate. What that means is that on any given day, around 2% of 1 to 2 bedroom apartments are available to rent. And that means if you're not a great rental applicant, landlords are unlikely to choose you. You could have dozens and dozens of applicants for a single rental property. And then the final piece is that wages have been relatively stagnant for the last couple of decades. There's been efforts to increase the minimum wage, but overall the cost of living has outpaced wages on the whole, and so there's a mismatch between what people make and how much it costs to live in San Diego. Our organization specifically, Father Joe's Villages, is a large comprehensive homeless service agency, and we house over 2,000 people on any given night in a variety of housing programs, ranging from our interim program to transitional housing to both permanent supportive housing and affordable housing programs. We have a range of other programs in addition to housing, including food services. We have 2 cafeterias on site that serve food to those who reside with us, but also to those who are on the streets. We have a state-certified child care program. We also have vocational training for those who are on more of a work track and able to work. We have a chaplaincy program. We have a day center, which is a program for those on the streets to access social services, not just ours, but those of other organizations as well. And we have a contract with the city to provide those services to those on the streets. We have wellness programs, substance and alcohol abuse programs, and a variety of other programs. But of course, we also have, since I run the program, I've got to highlight that, of course, a health center embedded within the rest of the village. But really, the health center is just one of dozens of services that the village offers. It's one of the items on a menu of services available to our clients here at Father Joe's Villages. So talking about the health center specifically, we are a single-site healthcare for the homeless, federally qualified health center. We are not a community health center. We are only an HCH site. We offer comprehensive services that we really work hard to integrate with the rest of the village. We offer primary care. We have a dispensary on site, psychiatry, behavioral health, laboratory on site, case management, social work, community health worker, etc., a large range of services. And a little bit different than a lot of other health centers, we are a continuity clinic for the family medicine psychiatry combined residency at the University of California, San Diego. These are physicians who are going through 5 years of residency to become board certified in both family medicine and psychiatry, and they are a big source of providing care to our homeless neighbors here in San Diego. Each year we serve about 2,300 unduplicated patients, unique patients, through about 13,000 visits per year. I also want to talk a little bit about the County of San Diego, which is the primary government public health agency here in San Diego, specifically the county's Health and Human Services Agency, HHSA. It's the largest agency of its kind in the country after the federal government, and within it, of course, is embedded public health services of a variety of sorts. It serves millions of San Diegans and those in surrounding cities through these variety of programs. And interestingly, in 2016, Housing and Community Development Services were placed under HHSA, which is a little bit different than what is done in a lot of other municipalities throughout the country. All right, so enough of the background. Let's get into what actually happened with the outbreak. This figure that I'm showing now is what's called an Epi Curve, and it shows the number of cases, or the incidence by week, of hepatitis A cases here in the San Diego area over time. It starts back in October of 2016 and goes through the beginning of February 2018, this year. So what we can see is that the first cases of hepatitis A started way back in November 2016, and they actually started out in an area east of the city of San Diego called El Cajon, about 15 miles east of here. There were a few cases, sporadic cases, more than we would usually see, but still not a huge number. But we saw that that started to escalate into February and March of 2017. And in March, the public health authorities, HHSA, actually sent out a health alert to providers, clinicians, hospitals, clinics in the area, letting folks know that an outbreak was occurring and that they had already identified that those mostly affected were those who were homeless and or folks who abused illicit drugs. Soon after, at the beginning of April, we were contacted here at Father Joe's Villages by public health authorities to try to determine how we could collaborate and most effectively address this outbreak. A couple of weeks later, we started supporting the county and having max vaccination events on our property on a very regular basis. The outbreak, unfortunately, continued to worsen into the summer and was plateaued through most of the summer into the early fall. And then we got to September of 2017, and a local state of emergency was declared in order to devote more resources to the outbreak, which I'll talk about in a moment. And slowly things started to improve after that. In October, the state of California declared a state of emergency for the entire state in order to devote more resources to ensuring vaccines were available to those who needed it. Things continued to improve until January 2018, when the local state of emergency was finally ended. And technically, we haven't called the outbreak quite done yet. This figure doesn't show it because I don't have access to the most recent figures, but there have been a few more cases identified about 20, 30 miles north of San Diego within the last few weeks. So we're not quite there yet, but we're at the tail end of this outbreak, and we're hoping that we see no further cases and can declare this outbreak officially over. The little red area down in the bottom right highlights the fact that often it was difficult to predict whether or not the outbreak would be improving or worsening with time, and that was because of that incubation period of 15 to 50 days. What that means is there could be, and there still could be, people out there who are infected but haven't yet shown symptoms. And weeks down the road, they could suddenly pop up as being symptomatic, having symptoms, be identified, and we could have a worsening in the outbreak. Looking at the bigger picture in the statistics and what happened, the most recent numbers that I have access to, which are from the middle of February, were that there were 580 cases of hepatitis A identified in the county of San Diego. 3.4% of folks who contracted hepatitis A died. That's a much higher mortality rate than most other hepatitis A outbreaks, and I'll get into why in a little bit. 69% of folks who contracted hepatitis A were hospitalized. Again, this is much worse than a lot of other hepatitis A outbreaks and reflects the population affected. So getting into what were the risk factors for becoming infected, and also why the outbreak was so bad, what we found was that 62% of individuals who contracted hepatitis A were either homeless and or users of illicit drugs. 17% had hepatitis C and 5% had hepatitis B. The hepatitis C and hepatitis B are particularly important because those individuals had underlying liver disease. They already had problems with their liver. So when you added the next insult of hepatitis A on top of the pre-existing liver condition, they were that much more likely to be negatively impacted, end up hospitalized, and potentially die of infection. And the homelessness and those using illicit drugs really gets at why so many people were hospitalized. Homeless individuals are often much sicker than other age and gender-matched peers in the rest of the community. They've got a lot going on in their lives, and thus their bodies aren't as able to fend off and fight the hepatitis A infection, and that really drove that higher rate of hospitalization and death. Interestingly, 53% of those who contracted hepatitis A had a reason, an indication, to get the hepatitis A vaccine series before the outbreak even happened, but never got the series. So that has some public health implications that I'll get into later. The outbreak has unfortunately spread to Utah, Kentucky, and other parts of California, including LA, Santa Cruz, and Monterey counties. And this outbreak has been particularly unique in that the mode of transmission has not been a contaminated food or water source. It's really been mostly person-to-person contact, or person-to-person transmission and contact with the contaminated physical environment. The public health experts at the county level have really been crunching the numbers, and they have not been able to find that it was, that restaurant over there or that water source that caused it. It's really person to person and the physical environment. Now I want to talk about interventions and efforts that were employed to combat this outbreak and how we tried to slow this down and get a handle on it. There are really three components to addressing this outbreak. Number one is education and communication. Number two is inoculation or vaccination. And number three was sanitation. And I'm going to talk about each of these areas separately, and I'll talk about what public health officials did to address these areas, and then what we did here at Father Joe's Villages specifically. In terms of education and communication on the health department level, on the public health level, they were very active in putting out regular press releases so that the community and stakeholders knew what was going on and had up-to-date information. They also produced a large amount of educational materials for community members that were put out directly to the community, but also given to stakeholders, folks like us, to disseminate into the community. They were also in the media very, very frequently talking about what was going on so that the public was aware. They were on the news, on the radio, etc. And they also were in very regular contact with stakeholders like federally qualified health centers. I can say that a number of folks from the health department came to our physician council at our local HCCN and talked to the CMOs and medical directors on 2 occasions about the outbreak, what was going on, to update us and to keep us in the know and partner with us on ending this outbreak as soon as possible. In terms of the village's response, Father Joe's Villages, my organization, a number of things were done. One of the most visible was signage and educational materials that we put out. This was both for village residents, but also for health center patients and those who are on the streets and visited our day center. An example of one of those handouts, an infographic that we produced, is on the presentation right now. And this was something that we laminated and put up in very conspicuous areas on our property to let folks know about what was going on. In addition to signage, we also talked with all of our patients about what was going on and really made it clear that to them on a verbal basis what was going on with the outbreak and the importance of protecting themselves and getting vaccinated. We were also involved in media response. I certainly can say I was personally in the media much more so than I ever had before, whether it was print media, TV, radio, etc. We were also in very regular contact with county public health officials. I can say at least on a weekly basis I had some form of communication with county public health officials, and also, as I mentioned before, met with them in person on a health center network level. And we also had meetings between myself and the other leaders here at Father Joe's and county public health officials. We at the village also had regular internal meetings in order to determine what next steps we needed to take to help combat this outbreak. And then we also participated in state legislature discussions on the outbreak. I actually went out to Sacramento a couple of months ago and took part in a legislative panel on the outbreak to reflect on what happened and how we can learn and do better next time. In terms of vaccination, inoculation on the public health level, a lot of what the public health department did revolved around recommendations about who to vaccinate and then getting the vaccine out there. So in terms of who to give the vaccination to, they really made it very clear and put in all of their materials that all homeless individuals should get vaccinated and those who were transiently housed. And they made the vaccine freely available to community partners and stakeholders, folks like us, so that there was no actual material cost, acquisition cost for us to get vaccine, and we could give it to as many people as possible. And they also provided temporary housing to folks who were actively infected. So what that meant is that if a patient came to me in my health center living on the streets and we suspected they had hepatitis A, instead of evaluating that patient and first determining if they needed to go to the hospital, but if they didn't need to go to the hospital, rather than discharge them back out to the streets, I could call up the county and work with them to get them into a temporary housing situation so they didn't go back out to the streets and potentially transmit the disease to other homeless individuals. The county held a substantial number of events to try to vaccinate folks. These were mass vaccination events. It's really kind of staggering when you think about the amount of coordination that it required to put all this on. They held 2,844 events that led to, in total, 26,271 individuals vaccinated. And to get this done, they had to hire quite a number of per diem RNs to really get them out there in the community and provide the vaccinations directly. All in all, during this outbreak, in the county of San Diego, 123,392 vaccines have been administered. So an incredible amount of work getting vaccine out there. So not all these vaccines obviously were provided by the county, but this is globally what happened across the entire county. Another big part of it for public health was communicating who should get vaccinated. There was a difficult issue of the worried well phenomenon. There were a lot of folks who didn't come to the downtown area, which was really where most of the hepatitis A, individuals affected by hepatitis A were located. They didn't have contact with homeless individuals, and they were not folks using illicit drugs. They really weren't in high-risk groups, and they were unlikely to be infected. And so there was a lot of messaging from public health around who should get vaccinated. And the main reason to do that is that they needed to ensure that the vaccine was available and there was enough stock to get it to those who were actually high risk so that we could slow down this outbreak. And related to that supply issue, as I mentioned earlier, the state of California actually declared a state of emergency related to this vaccine supply issue. And that enabled funds to be released to buy vaccine and make it available to everyone who needed it. In terms of Father Joe's Village's efforts around vaccination, we made it very clear to all of our patients that we recommended that they get vaccinated. We talk this up constantly at with all patient encounters, whether it was our triage nurses, medical visits, psychiatric visits. We really just put it out there in all forms possible. I wrote a standing order for our nurses so that they could provide vaccination without the intervention of a doctor, and that really empowered the nurses also to talk more about hepatitis A. We encouraged all of our staff to get vaccinated and provided them with resources to achieve that vaccination. And then we directly supported the health department in holding their mass vaccination events 4 days a week on site on our property for months on end. And those events actually are just being ramped down over the last week or so. So it's been going on for many, many months at this point, the mass vaccination events here at Father Joe's Villages. Moving on to sanitation and the public health response to sanitation needs. The biggest and most visible thing that public health authorities were involved in was washing streets with a bleach solution. As I mentioned, this outbreak was quite different than most other outbreaks in that there was no contaminated food or water source, and rather it was person-to-person transmission or contact with a contaminated environment. And so the response was really to get out power washers and wash the streets and other inanimate objects around the streets with bleach solution to kill the hepatitis A virus where it was. It also involved putting hand washing stations out on the street so that those experiencing homelessness were able to wash their hands and protect themselves and their neighbors. And it also involved getting portable toilets out on the street so that those experiencing homelessness had a place to go to the bathroom rather than having to defecate on the street. And a little bit more about that, over the last couple of years, toilet access has been a definite difficult point here in San Diego. The number of toilets overall has gone down slightly over a couple of years due to some very real concerns about security in and around those toilets, and also concerns about cost. I will say that the village provides 24/7 access to bathrooms for those on the streets, and we keep those clean on a very regular basis with cleaning products that kill hepatitis A. But yet, with the increase in the homeless population over time, the supply of toilets is still inadequate for the need. We're simply a single organization helping to provide that. And what that means is that we are worried that there was an increase in defecation on the streets and that that was a contributing factor to this outbreak. In terms of what we did at the village around sanitation, we provided hand sanitation kits to especially those on the streets, so they had easy ways to clean their hands. The clinic here changed its hand sanitizer to be benzalkonium chloride based. For those clinicians, nurses, etc. out there on the webinar, most folks know that alcohol-based sanitizers work pretty well for just about everything except for Clostridium difficile. But a lot of, I didn't know this when this outbreak started, a lot of us probably don't know that alcohol-based sanitizers don't actually kill hepatitis A. And so benzalkonium chloride is really the hand sanitizer of choice, especially within clinical environments, but also for hand sanitation kits and in other venues. Similarly, we changed our cleaning products to ensure that hepatitis A was killed by the products that we use. Our cafeterias were inspected and passed inspection to ensure that they weren't contributing to the outbreak. And we supported, as I mentioned before, the placement of hand washing stations by the county on our property to help provide places where people could clean their hands and not pass along hepatitis A. So now that I've gone through all that background about the response, I want to talk a bit more about the actual causes of the outbreak itself. One of the major causes is gentrification in the downtown area of San Diego and what that's resulted in. It's really as more and more buildings have been built here, high-rise condos and apartments, it's pushed the homeless population in downtown into a smaller and smaller area right around our organization in the southeast part of the downtown area. The next slide shows a picture that demonstrates the difference in San Diego from a couple of decades ago to today. And what you can see in the first picture at the top is that the number of large skyrise buildings is fairly small, and now today there are a large number of luxury apartment condo buildings and commercial development in the San Diego Padres stadium right there in the foreground. Another demonstration of this is our outreach maps. So what you'll see in these maps is where folks reside on the streets and where they're concentrated. And these maps go from September of 2015 to August of 2017 on 3-month intervals. And what I'm going to do is explain the first figure and tell you what each piece means, and then I'm just going to cycle through them so you can see the changes over time. These maps are centered on Father Joe's villages, which is where the black star is in the middle, and the green circle goes out about 3 or 4 blocks away. Each of the green dots represents approximately 10 or slightly more people, and the red dots represent 10 or slightly more structures, typically tents. And now I'm just going to cycle through the slides, and you can see how things change over time from mid-2015 to mid-2017. So I'm going to show you those same figures, but I'm just going to show you the first one and the last one so you can see the contrast between the beginning and the end. So what this really shows is that there's been a concentration of those experiencing homelessness onto a couple of streets very near to Father Joe's villages. It also shows that there's a larger number of tents or other structures in which people are living. But really what it means is people are living nearly on top of each other, or were living nearly on top of each other during this outbreak back in 2017. So beyond the issue of gentrification and the concentration of people into a smaller and smaller part of downtown, which meant that it was much easier to pass fecal material from one person to another, was the issue of decreased availability of restrooms and hand washing in the downtown. And again, I've already described the background on that, but that was definitely a contributor to what was going on. The next issue is substance and alcohol abuse among those experiencing homelessness. This was both a direct cause of the outbreak in that the abuse of substances provided a vector or a means of transmission of small amounts of fecal material from one person to the next, but it also resulted in people having a lower overall health level, which meant they were more susceptible to serious adverse outcomes from hepatitis A and death going along with that. The other big difficulty with and cause of the outbreak is that hepatitis A particularly is hard to control, and that really relates back to that long incubation period of 15 to 50 days. And it means it's really hard to predict where things are going. Are we really doing what we need to do? Are things getting better, or are they getting worse? And you often don't know the effect of an intervention until at least 2 to 6 weeks later, if not longer. The other significant issue is the high rates of chronic liver disease. This relates some back to alcohol abuse and substance abuse, but also hepatitis B and hepatitis C prevalence. And that prevalence of those two diseases is quite a bit higher among those experiencing homelessness compared to other groups of people. So simply put, their livers are not very healthy to begin with, and that means when they get hepatitis A, they're much more likely to get very ill or potentially die. But if we really get down to it and we think about what is the true root cause, we look at all of these other causes, we do our root cause analysis, what issue relates back to all of these other causes? And ultimately it comes down to homelessness. Homelessness ultimately is what resulted in this outbreak. And so what we have to take away from this is if we can't address homelessness, we're not going to be able to effectively prevent these sorts of outbreaks. And now I'm going to reflect a little bit on lessons learned and what we took away from this. On the prevention side, the reflections are that it's really important to vaccinate high-risk populations against hepatitis A and B. As I mentioned at the beginning of the talk, 53% of those who contracted hepatitis A should have been vaccinated against hepatitis A if the routine vaccination schedule had been followed, the CDC ACIP vaccination schedule. And then also, as I just mentioned, from a prevention standpoint, ending homelessness is absolutely essential. There's no escaping that homelessness drove this outbreak. In terms of combating the outbreak while it's occurring, the most important thing, far and away the most important thing, is aggressive vaccination. Vaccination is really what's going to give people immunity so that even if they become exposed to Hep A, they're much less likely to contract it, or if they get it, they will get much less sick. It's also really important to maintain very close and regular contact with public health authorities. That was extremely important to us as a health center and as a homeless service agency in order to be at the cutting edge of what we could do to address this outbreak. It's also important to consider outbreaks in your emergency plan as a health center. So a lot of us think of emergencies as earthquakes or fires or mass casualties, things like that, but it's really important to consider outbreaks as well. Interestingly, reflecting on the outbreak, there was a much higher acceptance of vaccination during the outbreak than people would normally accept vaccines. So even among those individuals who would consider them anti-vaccine folks, they were very receptive to the vaccine. I had multiple patients of mine who said, I've never gotten a vaccine in the last 20 years, I don't believe in vaccines, blah, blah, blah. And yet they wanted the hepatitis A vaccine and they were asking me for it. It wasn't even me bringing it up. It was them asking for it before I even got a chance to talk to them about it. And the last lesson learned that's very important is to ask for help when you need it in these sorts of emergency situations. Whether that's monetary support, supplies, technical assistance, whatever it may be, put it out there. You might not get it, but if you don't ask for it, you definitely won't get it. So work with your resources, develop new resources, and ask for help. That's the end of my presentation, and I just wanted to say thank you specifically to a number of individuals. I wanted to thank Dr. Eric McDonald and Dr. Sayon at the County of San Diego. I will make a brief mention that this presentation does not represent the opinion of the County of San Diego, but they were certainly helpful in gathering some of this material. I also wanted to thank Deacon Jim Vargas, who's the CEO of Father Joe's Villages, my organization, and my boss, Ruth Brulin, who's the Chief Program Officer here at Father Joe's Villages. And with that, we will take questions.
Great, thank you, Dr. Norris. As you know, I was in San Diego last year, and I visited your health center and saw the development all around the clinic and the public health department vaccinating folks right outside the door of your clinic. And so I have a particularly good view of this, and so this was a really meaningful presentation. We've gotten a couple of questions, and I have some that we can address. So I guess the first one, just really quickly, are you able to share the copy of that sign that you had posted throughout your campus?
Absolutely. I'm happy to share that. I can provide that to you, Michael, and then we can get it out to folks.
Great. We can post it with all the other materials. Another question was, do you know the cost associated with the sanitation efforts to combat the outbreak? Or do you know where to find that?
I do not know the cost of those efforts, and I'm not sure where to find them. I have no doubt that those figures are available somewhere. I know that folks from the public health from HHSA were planning on being, I see Eric McDonald on the call right now. He may or may not be able to answer that question, but I do not have those figures.
Okay, we can follow up with that. So David's asking, he's in Oakland, if you knew that there was a vaccine shortage during the outbreak and several counties couldn't document active cases, couldn't access any state vaccines or even buy any at $85 a dose till middle of December. Do you have any perspective on that you'd like to share?
So I can't comment on how vaccine was allocated on a state level in order to get it to needed areas in need. What I can comment on is the issue of the worried well being a major factor from my perspective that complicates matters. That, if you look at those numbers again, 123,000 vaccines administered, that doesn't mean 123,000 people were vaccinated, but let's say it's around 80,000 estimated. And the county put out there vaccinated about 23,000 people. That means there's let's say around 60,000 people on top of what the county vaccinated. Many of those people certainly were probably high risk, but we know that there were a certain percentage that were not necessarily high risk. And so making sure that that resource, vaccination, gets to those who need it is absolutely essential. So a lot of it is around messaging so that the resource is effectively utilized rather than going to groups who are not high risk. But in terms of the actual allocation of it to those counties, I couldn't comment on that.
Eric McDonald did share in the chat box a resource where folks can find educational materials that the County of San Diego has, so that that will be in the follow-up materials. So David asked again, what's your perspective on the effectiveness of street washing?
So I think it was fairly helpful. I don't know if there's a way to estimate and isolate the effect of street washing versus vaccination. I think on a public health level, vaccination definitely is more important in terms of combating the outbreak itself. Obviously, if you get vaccinated and you come into contact with fecal material that has hepatitis A, you're very unlikely to get hepatitis A. So that's really the most effective way to slow down and stop the outbreak. The street washing was because we were deploying massive efforts to vaccinate thousands and thousands of folks, and yet the outbreak didn't seem to be improving. It probably in part wasn't because of the very long incubation period, the 15 to 50 days. But also we got to the point where we said, hey, we've got to do more. We have to try other things. This isn't slowing down. We're vaccinating folks. We need to do additional things to combat this outbreak. Probably why the vaccine wasn't quite slowing down the outbreak was not, in addition to the incubation period, it was just that we hadn't hit that critical number of folks, percentage of folks we needed to vaccinate. So we're vaccinating a lot of folks, but it just wasn't quite enough folks. And so it was probably the combination of all those things that finally brought down the outbreak.
Right. So we've got a couple of related questions, and this is something I was wondering about too. If you could talk about the related advocacy or political dialogue around some of the instigators of the outbreak, such as homelessness in the first place, or the removal of the public restrooms. I know, like here in Nashville, they've been removing a lot of the public restrooms and public water fountains. So, and I'm sure a lot of communities can relate to that. So, is there any advocacy, or can you describe the kind of political environment around this?
Absolutely. There's been a lot of advocacy around these issues, and I always try to see the positive in anything that happens. And if there has to be any silver lining to this outbreak, it's that it's really sparked some deep soul searching here in San Diego about homelessness as a major issue that we must deal with. And I'm sad to say that it took a couple of dozen people dying in order to really spark that soul searching, but if anything's the silver lining, that's what it is. That's what we can take away, is we have to address homelessness in a more meaningful way. We can't wait. People are literally dying out there. And of course they've always been dying, but now they're dying more rapidly from this horrible infectious disease. So our organization has definitely been involved in talks with the city and county about how do we not just address homelessness, but also issues of sanitation and bathrooms. So definitely there's been a lot of work that has been reinvigorated or sparked because of this.
Great. So a couple more questions are coming in. Let me try and get to all of them. So David wonders if you can talk about the creation of a city-sanctioned encampment during the outbreak and the use of the outbreak to shut down camps or remove people experiencing homelessness, such as in El Cajon.
So the efforts to create the creation of a city-sanctioned encampment, which was here in the downtown area, was definitely sparked by this outbreak, and I think was a positive short-term development to address the immediate needs of those experiencing homelessness, to provide an option for those on the streets to get into at least short-term, a safer environment with better access to bathrooms and toilets. The use of outbreak I'm trying to understand the second part of his question. So I'm not sure I understand the second part of his question. So I think he's asking about moving folks, breaking up camps of folks and moving folks around. There were efforts to disperse folks who were living on the streets in order to make the population of those experiencing homelessness less concentrated. Those efforts, we don't really know what those efforts did in terms of improving the outbreak versus other interventions. The analogy I use is that can either be a very good technique to address an outbreak because it means people aren't living on top of each other and in such close quarters, and thus are less likely to spread the virus, or it could be a very bad approach in that it's like a fire, and to put out the fire, you're spreading embers all over your surrounding environment, and that could spark many other fires in the surrounding area, or it could put the fire out. From a social perspective, it definitely caused a lot of disruption for those living on the streets to shut down camps, those living on the streets. And we definitely saw that within our health center, the stress and anxiety that people experience.
Yeah, I suspect what David's getting to is related to the rise in encampments across the country and how closing encampments is often due to a public health concern, at least according to the local governments. So it's a tricky scenario. I want to get to Barry Zevin's question. He asks, how were the vaccines recorded? Did they get in medical records, state database, shareable in any way to know who got the vaccine and who didn't?
Yeah, so we're really lucky here in San Diego. We have an immunization registry called SDIR, so the San Diego Immunization Registry. And vaccines that are provided here in San Diego are, for the most part, wherever they're done, entered into that immunization registry. And so we have one repository where we can try to make sure that people aren't getting duplicate, triplicate vaccines inappropriately, and that the second hepatitis A vaccine, which should be administered 6 to 12 months after the first to ensure lifelong immunity, to make sure that happens. I won't say that there were no duplicate or triplicate first vaccines. That certainly happened, but this registry certainly helped prevent that and reduce it. So it shows the power of big data, so to speak, in making sure that resources are effectively utilized. It certainly went into our medical record here at our health center for our patients who we administered the vaccine to, and we coordinated with the county on that.
I wanted to mention that Dr. McDonald shared a link to the County of San Diego's resources, and we've put that in a web pod on your screen. You should be able to click to go to that website. I just want to make sure that I'm getting to all the questions that were submitted. I wonder, Dr. Norris, if you can kind of imagine the scenarios of much smaller communities. San Diego is one of the biggest cities in the country. What do you recommend for communities like Louisville, Kentucky, or somewhere else who are struggling with a Hep A outbreak but have a much smaller network of providers? Can you give any kind of advice for a much smaller scale?
Yeah, I mean, I think the power of having a smaller community is you can potentially get all the stakeholders in one room together to really coordinate effectively and figure out what steps you need to take to address the outbreak. The flip side is, as a smaller community, you probably have fewer resources, but I think that's where that advocacy piece becomes really important, and asking for help and really working with, say, state-level officials to get the resources needed, to get, if needed, a state of emergency declared, and allocate whatever's necessary to stop the outbreak. So asking for help, I think, is absolutely essential.
Somebody notified us that the link isn't working. We'll get to that. And if we don't fix it during the presentation, we'll follow up with that. So you got to this a little bit already, and we've got about 5 minutes left for Q&A. How do you envision this being an opportunity moving forward to educate the larger public health community or just the public at large about homelessness? What's the role of healthcare for the homeless health centers in educating the rest of the community from their distinct expertise on homelessness?
So I think it really highlights the connection between homelessness and public health issues, that these are not two separate issues, but they're overlapping issues, and homelessness has very significant public health implications beyond just the social concerns and the concerns about human dignity and existence on this planet. And so I think highlighting that and using this as an example of how if we don't address homelessness and those social aspects of things, that public health suffers, and that costs money, that costs lives, people die, and really using this as a case study to learn and grow and not forget and do better next time.
Great. There are no additional questions in the pod that I can see. I just want to remind everyone of the CME pod on the right hand of your screen. Please follow those instructions to claim CME credit because it will disappear after we close the webinar. And you must claim your credit hours within 24 hours. This presentation was recorded and will be archived along with all the other sessions in the spring virtual training. We have more next week, and I hope you'll tune in. So we'll post these online at the conclusion of the whole event. When we close the webinar today, a brief survey will appear in your browser, and we ask you to please fill it out. That really helps us grow, and I appreciate your time today. Thank you to Dr. Norris for your presentation, and thank you for the rich conversation. And now the webinar is closed.